Good afternoon, everyone. I'm happy to introduce Tom Cox today. Tom Cox is the Vice President of OSF's Oncology Service Line, and most recently spearheaded the implementation and opening of OSF's Cancer Institute. Tom has served OSF since 1984, when he started as a nuclear medicine technologist at OSF St. Francis. Prior to becoming Vice President, he served as Director of Medical Imaging and Outpatient Oncology. For the last decade, Tom has been responsible for building the Cancer Support Services Program at OSF St. Francis. The goal of this program is to fully support the communities we serve through all aspects of the cancer care continuum, including prevention, genetic risk assessment, early detection, timely diagnosis and staging, evidence-based treatments, and survivorship. Welcome, Tom.
Good afternoon, everyone. Good afternoon. Can you hear me okay? How about now?
You can take it out.
How about now?
Yeah.
It's better for my singing act. I think this will work. Thank you, though. Okay, so I'm going to be talking for a bit today. Let me see how much time I have here. Sorry about that. About the Cancer Institute, and I'm going to be talking about kind of what we're doing today, but also what our vision is for the Cancer Institute as we continue to grow. And I just want you to know we're thinking big. We're thinking big for this community, this region, for all our partners throughout Central Illinois. So on this slide, you can kind of see the OSF hospitals, and we talk about how we want to partner with all of our health partners. And yes, we want to partner with our OSF hospitals. We want to also partner with our non-OSF healthcare providers throughout our communities. What we like to think in the Cancer Institute is that the tools and the programs that we have in the Cancer Institute are the tools and programs for all of the communities in the midsection of the state of Illinois. Our goal is to up cancer care, to up the level of care, to make it so patients don't have to get on a plane and fly to Rochester, Minnesota, or Houston, Texas, or fight traffic up in Chicago. Bring hope, bring opportunity, bring high quality care, bring research trials to our communities so that people don't have to go to those far-flung places to get high level care. So from a vision and strategy perspective, one thing I want to mention on that first bullet is precision-based multidisciplinary care. We're big advocates of multidisciplinary care. We have 10 multidisciplinary conferences we do each week where rad-onc, med-onc, surgery, if it's lung cancer, pulmonology, radiology, pathology, they all come together and discuss cases and determine what is the stage, what's the next best treatment, are there any clinical trials that are applicable, are there any supportive services that could be utilized to assist the patient, and then is there a local physician in the region that we need to have on those meetings that we need to communicate with. A seamless cancer journey, I'm going to talk about the entire cancer continuum and how we often talk about how we want to take the hand of our communities and walk the path through cancer for an entire lifetime. We also want to take the hand literally, sometimes figuratively, sometimes literally, of patients as they have acute cancer, and we want to make sure that we engage them and coordinate care quickly and move through the cancer continuum. Prevention of cancer is very important to us. We've put a teaching kitchen into the Cancer Institute. The main reason that teaching kitchen is in there is to help people understand what we put into our body frequently increases or decreases our chance of cancer. I've heard that obesity has kind of slowly been surpassing smoking as a primary risk factor for cancer. So we take medical students and residents and get them into teaching kitchen and try to have them understand early in their career how to advise patients on what's your diet, can do for you or against you. Research, I'm going to talk a lot about research in subsequent slides. Guiding principles, I talked about multidisciplinary care. Clinical excellence, we really want to bring cutting edge technology, cutting edge treatments, cutting edge early detection into our communities. Co-location of needed ancillaries. What we did in the Cancer Institute is take a full array of diagnostic equipment, put it all on the first floor of the Cancer Institute. If I get a tissue diagnosis of lung cancer, I'm going to go in there, be met by a volunteer who's going to walk me through my day, and I'm going to get my entire workup done in a single day. That's similar to the experience you would have at Mayo. Then those studies will be interpreted and they'll be presented at the Lung Cancer Conference on Friday morning. So within a few days, you have had your workup done and your case is at a conference and being discussed by a team of providers. The single point of intake, I'm going to talk more about that. I want to talk about the patient-oriented flow. So that single day workup is part of the patient-oriented flow, but we've also communicated with all of the departments in the Cancer Institute, and we've leveraged our information system to know if there's a day I'm going to come walking into the Cancer Institute to see a surgeon on the third floor. But I also have an outstanding order to get my PET scan done. We're going to make sure we do those two things in the same day, that we value your time, that we get you in there and get that done in an efficient manner. Patient-oriented culture. If any of you ever go into the Cancer Institute, I would feel very confident to say you are going to feel the culture. We did classes for everybody that works in that building to help them understand the unique needs of cancer patients, to ask them to be advocates for cancer patients and their families, and that when we interact with patients, we want to make sure we have a conversation along with what we're providing for that patient of, is there anything you need? Is there anything we can do for you? Because if we hear that, we want all of our employees, all of our mission partners to know we've got a full array of supportive services. So if I'm in that hospital, in that building to get my 3-year post-lung cancer treatment surveillance CT, my expectation is the CT tech at the end of that scan will say, Mr. Cox, is there anything we can do for you? How you doing? Do you need anything? And maybe it's been 3 years, but I used to get up and run. I used to be really active, but I put on weight. I haven't been able to do that. I'm depressed. I'm worried about lung cancer coming back. And that's the day I decide to talk about it. So that tech knows we've got exercise specialists in the building, dietitians, counselors, and can say, well, let's get you to talk to somebody if you want to. So that's what we try to do. That's why we want all types of cancer imaging done in the building. I will walk quickly around the cancer continuum as we think of it. Prevention and education. I talked about the teaching kitchen. We also do smoking cessation, radon education, skin safety, assessing risk. We're really expanding our genetic assessment program where we will do surveys, and if it turns out there's a very large familial history of cancer, then we will set up an appointment with a genetic counselor, and you can determine if you want to do genetic testing. If we determine through genetic testing that I have an extremely high risk of cancer, of a certain type of cancer, you'll then become part of our high risk program, and we'll design a screening regimen so that we catch it early. Maybe I'm predisposed to colon cancer and I get colonoscopies every 3 years, every 5 years instead of every 10. So genetic risk assessment, we're really trying to grow that. Screening and early detection, well, you're going to hear a little more about some research we're doing in early detection. We really want to try to find cancers early. It's about controlling cancer, how you can control your interactions with cancer in your life by your diet, your exercise, when you get screened, getting genetic assessments. Try to avoid cancer, but then if you get it, catch it early when it's much more treatable. And timely diagnosis and staging, I talked a little bit about that. Evidence-based best practice treatments. We have proton therapy. We have a variety of ways to use radiation to treat. We have very good surgeons to where we can do complex surgery. We can freeze tumors, burn tumors, electrocute tumors, use chemicals on tumors. The idea is when we do those multidisciplinary conferences, my goal is that every doc in there knows whatever tool I need to pull out for that particular case, that particular genetic mutation, that person's immune system, that person's comorbidity, here's the tool I need and I want them to have it. Do we have every possible tool yet? No, we don't. But that's our goal. Our goal is to keep people locally to be treated with the same type of treatment options that you would have at destination cancer centers, because that's what we're building toward, is to be a destination cancer center. Survivorship, I do want to mention our survivorship program. It's a donor-funded program. A donor gave us a generous gift, and we have hired 2 nurses, a dietitian, an exercise specialist, and we have our counselors involved. Once treatment is over, sit down with our survivorship team and kind of build a program to get you back on your feet, back out running, golfing, gardening, doing whatever you want to do, try to really get you back to that best life after cancer. Part of the reason I'm passionate about that survivorship program is I've had 2 nephews that had cancer. And both of them told me the scariest point for them was when their treatment was over and this army of people that was helping them were gone. And what's going to happen? And, you know, my friends are looking a little weird at me, like, I'm different than them. So we want to stop that and give a team to help you get back to, again, to your best life after treatment. Okay, so I'm going to talk about our intake team. When you get a diagnosis of cancer, it can be overwhelming. There's so much coming at you, it's hard to remember everything. You don't know where to turn. We put together a team, a 4-person team, that we've really been talking to the physicians in the area. We want to be an easy button for you when you get something suspicious. It doesn't even have to be that you've been diagnosed with cancer. Maybe there's a lesion on a CT scan that the report says suspicious of cancer. Your doctor or you can call our intake team. Our oncology nurse will be talking to you either that day or 1 business day later. And we will collect the information that we need and hand it off to the appropriate next step. It may be our rapid diagnostic clinic. We've put together a clinic for those cases where not sure if it's cancer or not, that you can easy button, send to the Cancer Institute. We'll get it assessed. We'll find out if it is cancer. We'll get it into our multidisciplinary conferences and get it to medical oncology or radiation oncology or surgery. But we will do it quickly. And we want physicians to know that, okay, I'm not sure what to do with this, send it to the Cancer Institute. They're going to get it worked up and they're going to keep communicating with me. And this is where, when you reach out to us, our whole concept was we want to start navigating you then. You've reached out to us, you asked us for help. How can we help you? I had a family friend who got a hold of my wife and said their mother was at Carl in Champaign. And she's elderly, has nobody over there to help her. They wanted to bring her back so they could care for her, and they wanted her to be seen in the Cancer Institute. I gave them that number. They called me back the following day and said, I can't believe how easy that was. My mother is being transferred over to St. Francis, and she's going to live with us after she gets out. Couldn't have been happier with how that all went. So we started kind of slowly with that team. They were trained in January and most of February, went live the last week of February. Very slow start until our friends in business development started making sure people knew about our intake team. So now we have done 94 referrals, and we're getting more and more calls every day. I talked about the expedited workup. I think we can go through this. I want to talk about some innovation that we're doing right now. I put Epic up there because we're really leveraging our information system to make it clear to a primary care doc when someone's due for a screening. Have they had their screening? they can refer to our lung screening program and we'll take it from there. They can refer to the breast center, but we want to make sure they know when screenings are necessary. Our information system also tells a scheduler if they're scheduling an MRI, this person has had cancer, so schedule them in the Cancer Institute. The second innovation there, where it looks like those two people talking to one another, that is representation for natural language processing. We take every radiology report at St. Francis Medical Center, 280,000 of them, and it goes through natural language processing. That software pulls out actionable findings or recommendations. So I'll give you a real world example that happened. Patient went into the ED because he fell, thought he might have broke a rib. And yes, he did break a rib. But during the course of getting a chest CT, he also had a lesion that was the recommendation was to come back in 3 months and get that scanned. At the 3-month mark, it hadn't happened, and our team kind of kicked in and contacted the patient, contacted the physician, ended up getting it done, and that person ended up having an early stage lung cancer. So that actionable findings program is kind of a safety net to make sure that if something is supposed to be worked up or looked at again, that it actually happens. Liquid biopsy, the very first trial we did in our Breakthrough Treatment Center was a liquid biopsy for lung cancer. What does that mean? We draw blood and scientists have determined you can see circulating mutated DNA from certain types of cancer, lung cancer being one of them. So we were part of a trial where when people came in to get their lung screening CT, we drew their blood and sent it off to a sponsor. The results of that trial showed that 98% of the time, if it showed no circulating mutated DNA, you didn't have a lung tumor, you didn't have any lung problems related to cancer. So that could become a once-a-year blood test, much like PSA, because the PSA test is right around that same 98, 99%. If it shows circulating DNA, that doesn't mean you have cancer. It means you have an elevated risk, and we'll get you on the CT scanner, and we'll take a look to see if you do have cancer. But that's going to augment our lung screening program. We have a couple other types of cancers that we're rolling out a trial that is, again, a liquid biopsy. I would much rather someday, in an annual checkup, have 3 or 4 tubes of blood taken than get needles stuck into my lung to see if what's growing in there, or needles stuck elsewhere to find out what's going on in my body. Proton therapy is depicted by that gentleman with his arms up. Proton therapy, we're about the 42nd site in the country. There's one in Chicago, one in St. Louis, none in Indiana, none in Iowa, none in Nebraska. The first 2 patients we did came from the middle of Iowa. So the people will be coming from farther away. But what proton therapy does, it's able to deliver radiation much more accurately. Typical photon radiation is X-ray photons going through your body. You'll get an entrance dose, a dose to the tumor, and an exit dose. With proton therapy, it enters the body, doesn't interact much with your normal tissue. It stops and releases all of its energy. That's called the Bragg peak. So what we do is we utilize shielding, increase and decrease the energy for how deep it'll go in the body. Gantry moves around, robotic couch, and try to paint the tumor with those Bragg peaks. So we're dropping all the energy in those tumors and very little energy in the surrounding normal tissue. So we're doing a lot of head and neck proton therapy. You got your eyes, your brain, your airway. There's a whole lot of stuff going on in a small place here. So a lot of times when we use X-ray photons, we're doing almost whole brain radiation, which you don't really like to do. But with proton therapy, we're able to do things that we weren't able to do before, where we would have told somebody, we can't help you, or you have to go up to Northwestern, which, by the way, they're very full up there, and they've been very cooperative with us in setting ours up. Now we can help you. Complex left breast cancer. Complex left breast cancer means you're going to get chemotherapy, radiation therapy, and surgery. You're going to get all 3. Typically, it's X-ray photons. When you do X-ray photons on the left breast, you're also exposing the heart and the coronary arteries. Now, normal tissue can repair itself, but what we have found through the years is that coronary arteries do repair themselves, but there's scar tissue there. Scar tissue is a great place for plaque to attach itself to. So there is a much higher rate of coronary artery disease in women who have had X-ray photons. So now in this community, complex left breast for the radiation component, it's going to be proton therapy, and it'll be a much better service. Let's see. The surgical suite with the CT in it, that's our new brachytherapy suite. So we're going to be able to do the treatment, the imaging, the treatment planning, all of that while you're under anesthesia. It's great for prostate therapy, great for gynonc therapy, and it's a therapy right now that you roll all over the hospital. Surgery in one building, your CT scan in another building, your treatment in another building, with, by the way, applicators hanging out of your pelvis. So that's not it's a great treatment, bad patient experience. This is going to be a great treatment with a great patient experience. And then we have a robot there that's in our interventional pulmonary lab that allows us to biopsy people that we wouldn't have been able to biopsy. Much smaller, harder to reach lesions we can now biopsy. I won't spend too much time here. That's everything that's in the building. Lower level is mainly proton and MRI physical therapy. First floor is all of our diagnostic stuff. Second floor, I do want to point out here, we have our infusion center and then our cancer supportive services where we do our multidisciplinary clinics, our rapid workup clinic, our actionable findings clinic, but we also have dietetics, financial navigation, social work, counseling, palliative care, pastoral care, our navigators, genetic counseling. So really anything that could help you or your family, we've made it available. That's our goal. Whatever you need to take your mind off of what you're fighting, we want to provide it. And then the third floor, physician practices. Fourth floor, we have over 30,000 square feet of nothing that I expect someday it will be more clinical space. We're going to live in this a little bit. We have capital dollars approved for next year to do the planning and drawings for that space. I don't need to bore you with the construction schedule. I want to talk about research. So we really are trying to up our game in research, and we're doing it in several ways. The first way is I'm going to talk about a study that Dr. McGee did with a PhD from Harvard School of Public Health, where we are looking at how do we understand patients' relationships to their clinicians and their community, and how can we leverage that to have a better strategy to reach them and make sure screenings happen. Beat Cancer is a program where we're combining with OSF and the University of Illinois, and there's been $10 million set aside for 5 years, $2 million a year for projects where an OSF physician will partner with someone from the University of Illinois Cancer Center, which is their basic science cancer center, or their engineering school, or their vet school, and we will do projects that we think can, and I'll go into a little more detail on that, on what the trials will address. I want to mention 2 industry sponsored trials. We have the ability to do flash therapy. We haven't done any yet on the proton machine. That's where the intensity level of the proton beam is up by 700%. And a treatment that normally takes 20 minutes takes a couple seconds. And rather than having 25 to 30 treatments, you'll have 1 or 2. That is in its second human trial at Cincinnati Children's Hospital. We've actually sent a couple patients there. We are partnering with them so that when we become flash able, we're going to extend their trial and do patients in our community that'll be part of their trial. The other one is the nanoparticle and radiation. It's a joint effort between one of our surgeons and our radiation therapists. Certain types of tumors do not respond in the way we want them to radiation. Science has found that this particular nanoparticle when injected into certain types of tumors, make them more susceptible to be affected by radiation. So we're going to have in that surgical suite I showed you with the CT on rails, we're going to have the surgeon go in there and do the injections into the solid tumor. Then we're going to take them and we're going to take them to either our linear accelerator for photon therapy or take them for proton therapy and see if that drug does enable us to really fight that tumor more effectively. And then the Breakthrough Treatment Center, we've partnered with a firm called Origin Ventures. They specialize in bringing cutting edge science to health systems that have a lot of clinical horsepower, but maybe don't have a huge research footprint. They don't go to the big academia because some sponsors are a little reticent to go to big academia because you become one of hundreds of trials and it takes forever to get a trial up. Origin Ventures has helped us get our trial approval process down to about 60 business days to get a trial up and running. And they're bringing the types of science to our community that we've had a hard time having before. We started with that lung early detection blood test, that liquid biopsy. That trial went so well that product has been commercialized now. It's called First Look Lung. They picked 2 spots to roll it out. The first spot was OSF in Peoria. The second spot was Duke. So it's us and Duke who are going to be doing this rollout. They picked us because we have a very evolved lung screening program. So they want to piggyback off of that with that First Look Lung. We want to screen as many people as possible. If you can't or don't want to get a CT, but you're high risk being 50 or over, 20-year pack history of smoking or more, you don't want to get a CT, just put your arm out, we'll draw blood, we'll do it that way. And we're trying to screen as many people as possible. We're also part of a 10-site worldwide pancreatic early detection trial. We're very proud of that. That's got Mayo, Cleveland Clinic, City of Hope. So, we are in with some good company there. And you can see some of the other trials. We're getting into the treatment trials now. We have a late-stage endometrial treatment, a late-stage cervical treatment. We have a glioblastoma trial. And for those of you who have ever heard of someone with glioblastoma, that is very hard to treat. And we have a clinical trial that we're trying to get up and running that we think will give options. And that's what it's about, give hope and give options. Oh, and I did want to mention that we're developing an ovarian cancer screening that'll be sort of like going and getting a Pap screening every year. Okay, this is our rural cancer research project that Dr. McGee did with Dr. Atkinson at Harvard. And it really gave us some good information about where do people get the information about screening? Well, who do they listen to, and how can we leverage that? 70% of the people, which by the way, we had about 2,000 people who responded to our survey across OSF rural communities that we serve. 70% of the patients said they felt like they were up to date and screened for cancer. 75% of those patients said the reason they were up to date was their PCP. For those who have not been screened, the main reason was their health provider did not recommend it. So what that tells us is we have to have a very tight relationship with primary care practices around the state, especially in the rural communities, because that's where they get the information. You'll see they also take information from the people with their strongest relationship, family and friends. But they also put a lot of stock in what the primary care docs tell them. So we want to be able to give tools to the primary care providers, whether you're OSF or not, to help understand what you as a primary care doc can do to help make sure screenings happen. And then if there are communities that don't have access to screening, longer term, we're looking at, can we put some of our screening devices in a truck and go to some of these communities and make it easier for that to happen? Patients reported that certain behavior changes happened after receiving information from family and PCP. Physical activity, nutrition, cancer screening, stop smoking. That's all cancer control right there. So they get that from their family, they get it from their PCP. So we need to arm up our communities and our PCPs. 40% of them also prefer to get their information over the internet. And that's something we have an ongoing work doing, is to get more information on our internet presence. So where we're heading, I talked about how we need to really engage primary care. We need to make self-education on the internet very, very easy. And interestingly, rural and urban responders, because we did screen urban responders as well. Same screening percentages in self-reported screening. Vastly different reasons given for those who didn't screen. If you remember, the urban responders said, my PCP didn't tell me to do it. Urban responders, it was more around access to the screenings. Transportation to screening. Screening can't be done, I can't get to it because I work all day. A variety of things. Worry about copay, and that's another thing we have to do a better job, is helping people understand that for virtually all insurances, a screening does not have a copay. So we just have to help people understand that. Now, there are some without insurance, but we can, through the Illinois Breast and Cervical Program, we can get anybody a mammogram for free. And we also have our own ways of helping you get on Medicaid, for example, or a free screening day, which we do quite a few of those every year. Okay, moving on. Breakthrough Treatment Center. This is the result of our relationship with Origin. These are about 16 clinical trials that are on the way of either we're enrolling patients or will be soon, or we've completed, or the one in red, we decided we couldn't do it. And it ranges from a lot of different types of treatment, a lot of those smart medicines that are designed to arm up your immune system or to attack a certain type of cancer that emits a certain type of material or uses a certain type of material to grow. So we've done trials where there's a cytotoxic drug attached to a material that the tumor absorbs to grow. So they're bringing that cytotoxic drug along with. So a lot of work being done there. We are in the process of recruiting 3 medical oncology research physicians, and we think that we'll quickly get this list up much higher when we get more medical oncologists that want to be primary investigators on these trials. So the Beat Cancer Program, that's our relationship with the U of I, and this is what we had a day 3 weeks ago where there were like 25 presentations about potential trials for this year's 2 million. And this is what we wanted them to focus on: improve cancer risk identification and strategies for early detection, develop interventions to manage high-risk patients, develop surveillance and care models to monitor cancer recurrence. There's a histology tool that one of the U of I professors is working on that will give you instant histology. For us, when we send away for pathology or we do it locally, it's about 5 days. So that could shave 5 days off of finding out what's going on with a biopsy. And then measure underlying impact of proton or flash therapies on biological tissues. I do want to kind of show you what kind of volume we're seeing fairly early on in the Cancer Institute. So we've been open for 90 days. This is a look at day 30 through 60 and day 60 through 90. We're mainly a Monday through Friday right now. I expect we're going to be 7 days a week in the not too distant future, but right now we're Monday through Friday. Those top 3 are the physician practices on the 3rd floor. We have 2 head and neck surgeons that saw 315 patients. We have our gynonc practice who saw 585, and our surgical oncology 516. I will say that gynonc practice, we're blessed to have 4 providers. Gynecological oncologists are very hard to find. We recently found out that in Des Moines, Iowa, a really big city, they have virtually no gynecological oncologists. So we're hoping to to get over in that community to say, we can help you at least until you get providers back in your community. Laboratory, we're working on lab. We haven't had a whole lot of, those labs only came from the providers on the 3rd floor. In the meantime, we have a lab right by our front door in the Milestone building that gets overcrowded. So we're working on ways to get patients over to the Cancer Institute for their lab. And then all of that imaging, we have about 50 people come in every day to be imaged. All of them, I'd say 90% of them cancer patients getting imaged. I do want to point out proton therapy. 424 patient interactions in the last 30 days. That includes treatments, consults, CT simulation, in-treatment visits. I couldn't be happier with what we're doing in proton therapy. We are at much higher volume now than we expected to be 90 days into our program. And at the same time, our photon therapy and our gamma knife and brachytherapy, they are all up as well. So I thought we might cannibalize some of our other volume, but we haven't. We've brought in more patients. I want to show you the power of imaging devoted to cancer. This is our CT lung screening volume, and our fiscal year starts in October. And you can see in October, November, December, January, we weren't doing very well. We weren't doing very well because we were backed up on our CT scans, and the radiology department reduced our CT lung screening slots. What worried me about that is we were diagnosing less lung cancers during that 4-month period. We will eventually screen them, but you risk upstaging. If somebody did have something you were going to catch on a screen that you would have done in October, but you do it in February, that could have upstaged during that time. So we put a lot of pressure on them to add back. And then as we got CT scanners in the new building, we loaded up certain portions of the day with lung screenings. So now we had the biggest February we've ever had, the biggest March we've ever had, the biggest month we've ever had in April, followed by the biggest month we've ever had in May. You combine that with the liquid biopsy test, we are screening a lot of people. And I also want to show you the power of this lung screening. In 2019, the percentage of lung cancers that we diagnosed that were stage 3 or 4 was in the 60s, like 62%. Last year, the percentage of stage 3 and 4 that we diagnosed was about 38%. Now, over 60% are stage 1 and 2. So we've completely flipped that. The mortality rate for lung cancer is going down in the three county area that we serve locally. I will tell you also, Carl has a very robust lung screening program. We work together. So it's not just us that are getting that mortality rate down, but it is making a difference. This was a screening event that we did at the new building. I think the new building was a little bit of the draw, but we also had help by business development and marketing to let people know we were doing screenings. We had 156 attendees, did 23 lung screening CTs, 24 mammograms, 91 seen on the caravan for skin and oral cancer screenings, 31 referrals, 17 to dermatology, 2 to a surgeon, 9 to PCP follow-ups, and 3 to ear, nose, and throat from those oral exams. We completed 44 risk assessments and found that 31 of them met criteria to be high risk, possible high risk. So they're coming in to talk to our genetic counselors and see if they want to have genetic testing done or not. But I will tell you the 2 that we referred to surgeons were both from our lung screening program, and both of them look highly likely to have lung cancer, which is very sad, but it looks to be caught very early as well. So good thing they decided to come in and have that screening. I do like to share some recruiting just to show you the power of the building and our vision. If we can get people in town and talk about what we're trying to do and get them excited about what we're trying to do, we're having much better luck getting them to want to come work here. So you can see starting back in the fall, a breast surgeon, a hepatopancreatobiliary surgeon, head and neck surgeon, surgical oncologist. We have a radiation oncologist coming on the 7th of July who helped start up proton therapy in San Diego, and he did proton therapy down in Miami. He had gone to the University of South Carolina to start proton therapy, but during COVID, they decided to cancel that program, so they're not going to have proton therapy. So he was looking around, and proton therapy is a small field. He called us up and said, I heard you're starting a proton therapy program. Yeah, you want to come look at it? He came and looked at it, and now he will be here the 7th of July. Extensive proton experience, extensive brachytherapy experience, very interested in theranostics, which is another type of treatment that's really, really coming along. So that was wonderful. We're negotiating with really a mid-career breast surgeon. We have a urologist coming in, a colorectal surgeon coming in on Monday, and we have 2 medical oncologists coming in on Monday, research medical oncologists. And that is it for me. Any questions? Yes, sir.
The technology in American medicine is great, and the fact that it's in Peoria is wonderful. But for any of us who've dealt with insurance, just for a finger or a fall, it's daunting, and the time and things like that. I have a friend whose mother is a refugee. He's trying desperately to get her into this country because she has breast cancer. And is she out of luck? I mean, we have a great American medical program. We have something great here in this town. How does somebody get treatment without insurance, who needs it, who's a refugee, who's in bad plights? Does she have any chance to benefit from what OSF offers?
So we don't turn patients away. What we try to do for all patients is work with you. We have a financial navigation program where we'll sit down with somebody and say, what's your insurance? Can we try to maximize that insurance? Are you eligible for us to get you signed up for Medicaid? Depending on the type of cancer, there are foundation dollars available to help people with certain types of cancer, and we have a charity program. We also, for proton therapy, we have employed a third party that's very good at working with insurers to get protons approved. And we've been over 90% so far in getting protons approved. We've also been hosting visits by the big payers in the area, where they come into the Cancer Institute, we walk them through, we tell them what we're doing. What we're trying to show them is we use evidence-based best practice. It's a very reasoned process. We try to do as few fractions as possible in radiation, for example, and trying to kind of plant the seed with them that when we ask you for a treatment plan, we've really thought this out. And we've had good luck with those visits and establishing that relationship. We even had, we showed some of that screening day to Meridian, I think it was, and one of their people gave me a card and said, we really want to help you with these screening days. We can help people understand that there's a way to get you on insurance, and we have some dollars that could help with some of those screenings. So we're trying to have a good, open relationship with the payers. But I will tell you, if somebody can't pay, we don't turn them away. We figure out how to get it done.
Where do I start with questions? This is a fantastic program. Thank you so much for being here. One question is, you were talking about creating jobs, and we've heard that sometimes it's difficult to attract professionals here to Peoria. You apparently aren't having a problem with that. Is that what we're hearing?
It is. The problem is getting better. I'm not saying we don't have a problem. I'm saying it's getting better, and we have tools to make ourselves more attractive. I will tell you, in proton therapy, we couldn't get anybody to come here to look. There was a physicist, a dosimetrist, a therapist. They just, there aren't many of them, and they're thinking, Central Illinois, what are you people doing? New York Protons was phenomenal to us, and we sent our physicists, our docs, our therapists, our dosimetrists, and they spent weeks at a time in New York, and we trained up our own people. That's how we were able to get up off the ground. We had a dosimetrist that practiced for a year before she did a live patient. And then we backfilled with therapists and dosimetrists and physicists. And the way we did that is we really had to incentivize those positions, because those are hard to come by too. But we talked about sign-on bonus, retention bonus, the ability to learn protons, and tried to make ourselves as attractive as we could. And we also went to the schools around the area and even pushed the definition of around the area and said, we want to be a clinical site for you for therapists, and get them in here, get them a good experience, and get them to stay. And that happened twice for us.
Fantastic news. The last question I have is, you showed us senior level positions, but there must be hundreds of other jobs down the line in terms of operating the equipment, keeping the equipment working. Is that a great story too, all the jobs that you're creating?
So we definitely created jobs in the Cancer Institute. It was probably over 100. I mean, it wasn't thousands, but by the time we get where we want to go, it might be. But for sure, some of the people transferred in from other areas. We're trying to get all of our cancer care under one roof as much as possible. But others, we attracted them and brought in new people. And like I said during the talk, every one of them had to go through training about being an advocate and how you can be an advocate for cancer patients and their families.
You've described good collaboration with other facilities and practitioners. Would you describe the relationship with Illinois Cancer Care?
So Illinois Cancer Care provides all of our medical oncology right now. All of it. They come into the building to do our multidisciplinary conferences. We are recruiting 3 research-minded med-oncs that are going to help us get our phase 1 clinical trials up and running. That's something that, as a busy clinical practice, Illinois Cancer Care offers clinical trials, but typically late-stage trials. It takes a lot of work on those early phase, and you have to build a team. They weren't as interested in that type of thing, which is their busy practice. So we're bringing in our own med-oncs to do that, but they are our primary providers of medical oncology. Most of our infusion happens at Route 91 at their building. They are coming into our building to be part of those visits where you sit down with a med-onc, a rad-onc, and a surgeon. They've always been good partners with us.
On time, I know I'm going to be the last one. I have a comment and then a question for you. You mentioned the importance of our primary care providers. Dolly Mama and I are sitting here talking because we both lost our husbands. We wish this would have been here 5 years ago, so thank you. The importance of being informed and asking questions of our primary care providers. I think that's something educationally wise we all have to be. You also mentioned a kitchen and the importance of caring. What are you doing for the caregiver and how we can help and educating?
So from a caregiver perspective, that's something our navigators try to really do when we realize there's a close caregiver. If we get permission from the patient, we try to make sure the caregiver gets the same education that the patient gets. And here's what you can do to assist your loved one. We have caregiver support groups. So we realize the importance of that, and it typically comes through our navigators. We've invested heavily in navigators. Not many places have 16 of them like we do, and they're subspecialized by cancer type. They really become the lifeline for the patient to reach out to. I will tell you, though, we have some work to do on the caregiver side as far as like getting some sort of educational package that we can do and that type of thing. But one thing I'd like to mention is when we do our multidisciplinary clinic visits, we have designed those rooms so that they have a big two video monitors. One video monitor is for imaging and pathology and that kind of thing. The other one is for remote attendance. So the other day we had a power of attorney for a patient who lived in Houston, who was on the screen listening to his mother's discussion, asking his questions, asking, Mom, do you get that? Do you have that? So it's designed that whoever you want to have there, and the room's big, so if you bring people with you, that's all fine too, to make sure that whoever you need to hear those discussions, you can have. Now, some people don't want a lot of people to hear it, so you can do it that way too, but we're trying to really, however you want to walk this path, we're going to help you walk it in your way.
And then, did we see on the screen that August 20th is your next screening day from that flyer?
Yes, don't hold me to that. I think that's what it is. If it was on there, yes, because the person who knows made that slide for me.